Good afternoon. This is Lisa Dulski-Watkins with the Millbank Memorial Fund. Welcome to our monthly topical webinar. I'm very delighted to have with us today our presenter from the Rhode Island Office of the Health Insurance Commissioner, Mr. Corey King. But what I'd like to do first is introduce my friend and colleague, Deborah Hurwitz, who has been working in health reform in Rhode Island for many years under many important roles. And currently she's the Executive Director for the Care Transformation Collaborative, the CTC of Rhode Island. Deb provides program administration, contract development, and strategic planning for this initiative. She has a strong clinical and administrative history, has been doing great work, and I'm going to turn it over to Deb to talk about some exciting publications they've had in the last couple of weeks, as well as to introduce Corey King, our speaker.
Great. Thanks, Lisa. Can you hear me okay?
Yeah, we can hear you fine.
Great. Okay. So just a reminder to, everyone on the phone a few months ago, I think before the holidays, folks have been presenting out on this concept of investment in primary care and sort of where they're at in their state, that agenda forward, which has kind of now, I think, become a broader national discussion, which is fantastic. And so at that time, I volunteered Corey to come and talk to us about the affordability standards in Rhode Island. And the timing was pretty good to do this now because there's been some revisions to the affordability standards. And so Corey will talk all about that. And before I turn it over to Corey, I just wanted to mention that we did recently have a publication published in Family Systems in Health. And it's a brief report. It's in the policy section of the journal, and it's called Rhode Island's Investment in Transportation. And it's a case study, essentially, of sort of like how things have evolved here in Rhode Island and sort of what we've learned and sort of the takeaways for folks that might be heading down this path. I've sent the article to Lisa, and she can distribute that to everybody who's interested. And also, we just released our annual report for 2019. And so that's sort of like, just a nice thing to look through, but you can sort of see, how, the kinds of work that we're doing. But in the article, we talk about, sort of what precipitated this move towards investing in primary care. And it really was a primary care crisis at the time. And then some of the structural and legislative pieces that came to bear that sort of created the Office of the Health Insurance Commissioner and some enabling legislation around the focus on primary care. And, over the years now through the Office of the Health Insurance Commissioner, implementation has been driven in part by the affordability standards. You'll learn a lot about that today from Corey. And then we talked about, some of the, work that we did around patient-centered medical home. You all are really familiar with that type of work. And then some of the things that came out of our experience in implementing PCMH with regard to other clinical programs that we have since really focused on, and that being integrated behavioral health in primary care, and then community health teams that address the social needs of patients, as well as behavioral health needs. So I welcome, and urge you to take a look if you'd like at the article. And if you have any questions about that, let us know. You'll see some conclusions about, things that work well and things that, we're still working on. And, some suggestions that states might want to take away in terms of, just sort of thinking about how you move forward with this. So I'll stop there unless Lisa or anyone has any questions about that, what I just said, and if not, then I'll turf it over to Corey.
Okay, great. I think we're all set. Anybody have any questions for Deb right away? Okay, great. Deb, I'll turn it back to you for a moment just to introduce Corey, and then we can get started.
Sure. So Corey King is our Director of Policy at the Rhode Island Office of the Health Insurance Commissioner, and he has been really the person implementing, overseeing the affordability standards, and most recently really driving a public process around revisions to the affordability standards to sort of, continue to move us forward and to, sort of use these standards to advance our efforts in various domains. So I think that's probably a good introduction to Corey King.
Thanks, Deb. That was indeed a very good introduction, and I don't have to cover most of the ground. Once again, Director of Policy at the Office of the Health Insurance Commissioner. In addition to overseeing the development and implementation of the Office's affordability standards, I also manage our prior approval rate review program for comprehensive major medical plans in the individual and group markets. And I can talk a little bit more at length about the relationship between affordability standards and our rate review authority. I've been with the office now for almost 6 years, though I've had some affiliation with it going back to 2011 when I was a student taking a class at Brown University, and I had a professor named Chris Kohler, who was the first health insurance commissioner of the state, and he brought me on as an intern, and it's been a great pleasure for the last 8+ years to see the development of policy from the standpoint of this office and just be part of the great work that's going on in Rhode Island, which Deb is a very key participant of. So my plan today is to give you all an overview of the affordability standards past, present, and future. They've been around now for about 10 years, and it's been an iterative process. And so I'm going to go through each of the iterations. But first, by way of background, the Office of the Health Insurance Commissioner was created by statute in 2004, and the agency has the traditional charge of an insurance department, which is to oversee the solvency of health insurance companies and to protect consumers. But our legislature, in addition to drafting a broad statute, also added additional responsibilities and duties for the office, which includes ensuring the fair treatment of healthcare providers, and also improving the healthcare system as a whole. And that latter one there really gives us the authority to pursue system transformation policies, including the affordability standards. So by way of background, the affordability standards are essentially a set of requirements for commercial health insurers operating in the state to follow in their efforts to improve the affordability of their products. And the standards are also designed to promote other aspects of OHIC's mission, including consumer protection, ensuring access to care, and promoting quality health care for our residents. I mentioned rate review a bit earlier. If you're interested in understanding the legal basis of the affordability standards, you'd have to actually look at our prior approval rate review authority, where when health plans propose premiums, which we review, they have to meet a couple of statutory standards, one of which is that the rates set forth have to be consistent with the proper conduct of the health plan's business, and secondly, they have to be consistent with the interest of the public. And it's that public interest criterion where OHIC has, I think, very appropriately construed a consumer interest in affordable health insurance. So much of access to care depends on having health insurance coverage. And so about 10 years ago, our first commissioner, Chris Kohler, looked at his statutory mandate and said, how can I systematize these expectations for insurance companies so that I can judge that the rates they're setting forth and the policies that as a health insurance company they're pursuing are advancing affordability. And that's basically what the affordability standards attempt to get at. This chart shows you that the work around affordability is ongoing, and this is only a window of 2015 to 2018, at which point Rhode Island has seen pretty favorable medical expense trends. And we've seen some of our state-level initiatives, such as the Care Transformation Collaborative, some of the regulations that the office implemented a few years ago, really showing some impact. But you can still see from this chart that the average premium increases, particularly in our group markets, still exceed the rate of economic growth being that red line there. So this is just one of many charts that I could show you for why it's important to focus on affordability and to continue to try to bend the cost curve. One of the goals of the affordability standards is to bring premium trends, and largely through the mechanism of bringing medical expense trends into closer alignment with economic growth. I consider these to be really the three pillars of the affordability standards. So payment reform and care transformation are two very, they're mutually reinforcing locus of activity that health plans and providers can pursue on their own, actually. But the third pillar is oversight and monitoring, and that's where I think the role of regulation in the state comes into play. To the extent that payment reforms and care transformations require collective action across the entities in the healthcare sector, when you can have a regulator like the Office of the Health Insurance Commissioner, or whether you have a purchaser like a Medicaid program that can set forth goals, requirements, and then conduct oversight and monitoring, you really, I think, put together a good blend of actions there. So again, much of what I'll talk about today really focuses on payment reform, care transformation, and then the role of the state in conducting oversight and monitoring. The first wave of the affordability standards was developed back around 2008, 2009, and then set into motion around 2010. And at that time, Chris Kohler, our first commissioner, I think in pondering what could he do that would be transformative and would, in theory, impact medical expense trends, he identified primary care as an area that we required increased investment and attention to. And so there's a lot of research out there that countries that have more resources in their primary care tend to observe better health outcomes, better healthcare system outcomes, and I think even recently some of the work that's being done by the Patient-Centered Primary Care Collaborative, if I got that right, I think it's the PCCCC, they're publishing research which looks at the association between primary care spending and certain system outcomes like ED visits and avoidable hospitalization. But the first emphasis was on primary care. How can we raise the level of investment in primary care in the state such that it's at a greater parity with other high-performing healthcare systems around the country, if not the world? But not just sufficient to focus on increased investment in terms of dollars, but can we, as the regulator, help guide the particular initiatives, policies, systems that those dollars are supporting? And so we put in a few more requirements. Around the time that the affordability standards are being developed, we co-convened along with our Medicaid program a multi-payer patient-centered medical home project, which eventually became the Care Transformation Collaborative of Rhode Island. And that has really been an invaluable resource for the state to conduct primary care practice transformation and to have discussions with payers and providers around system transformation more broadly. So increased investment in primary care, participation in the state's multi-payer patient-centered medical home, which would undergo in future years successive waves of increasing practice transformation. We wanted health plans to fund the state's health information exchange as a bit of an ancillary service for primary care providers to better communicate information about their patients. And then finally, the fourth requirement at first was very vague. It asked health plans to commit to comprehensive payment reform with hospitals, but it didn't have a lot of specificity to it. But subsequently, Chris Kohler, the first commissioner, decided he needed to put a bit more specificity to that requirement. And that's when we adopted what are effectively price controls for hospital fee schedules. We mandated the shift to DRG-based payment for commercial health plans, and we also required that health plans have quality payment programs for hospitals. So the initial wave of affordability standards, which lasted from 2010 to about 2015, focused largely on primary care transformation, increased investment, and also a bit in just cost containment and very modest steps towards payment reform in the hospital setting. The next couple of charts show you some of the outcomes of that first wave of affordability standards. You can see from this chart that as a market, at least as a commercial market, the percentage of total medical spending dedicated to primary care stood at 5.7% in 2008. It's increased today to over 12%. So we more than doubled the amount of funding in primary care, while at the same time requiring that health plans not increase their premiums to effectuate that. I think in practice, a lot of the shift occurred from limiting the hospital fee schedule growth, which allowed for a reallocation of dollars towards primary care. But there could be other ways that health plans satisfied that sort of budget neutrality condition to increase their primary care investment. But this is a chart that we often show stakeholders, and I think it shows a lot of success. We don't set a market-wide target. Each health plan in our market has a health plan specific target. I'll just also ask that if people are not on mute, and if you have anything in the background, if you could go on mute just to cut back on the background noise. But each health plan has a specific target, and we monitor those on a semi-annual basis. The next chart is from a study in Health Affairs that was published in February of 2019, which wanted to understand the effect of Rhode Island's affordability standards. And it was the first time we had a very robust scientific assessment done. And the authors of this study, and you can see the source here, and if you haven't already read it, I encourage you to, found that Rhode Island's medical spending actually was similar to a matched control group from residents of other states, but after the implementation of the affordability standards, we actually reduced spending relative to that control group. The study authors attributed this largely to the imposition of payment reforms and price controls on hospitals, and that makes a lot of sense. Prior to the implementation of the affordability standards, just anecdotally and based on information that hospital executives shared with me, I was able to determine that the annual fee schedule increases were reduced markedly after the implementation of the affordability standards. And during the first wave, we linked hospital fee schedule growth to a Medicare hospital price index. Today, we actually link it to the consumer price index, and I can talk more about that later. But this is a great chart. I like to show this because it actually shows bending the cost curve. All right, so moving ahead to the second wave of affordability standards, around 2015, there was a lot of work going on in the space of payment reform, and that was informed by the accountable care movement that I think was really being pushed by Medicare and the federal government. It was around 2015 that the Obama administration set forth some goals for the Medicare program to have 50% of Medicare reimbursements under an alternative payment model. And of course, with them, they're thinking about the Medicare Shared Savings Program and other payment models that the Medicare program offers to providers. And we were very interested in integrating some of that into the Rhode Island affordability standards. Previously, payment reform had focused largely on primary care and hospitals, but it wasn't comprehensive, and we didn't have any regulations around total cost of care payment models. So the 2015 revisions to the affordability standards specifically required that commercial health plans implement alternative payment models and satisfy annual targets for spending under alternative payment models. We also continued to push on continued transformation of primary care practices into PCMHs because our theory of action there is that transformed advanced primary care serves as a very effective basis for accountable care organizations and thereby increases the likelihood that we see successful outcomes in those alternative payment models that we're pushing. At the same time that we want continued transformation of primary care, we want to ensure that investments made in primary care practices are not retrenched by commercial payers. So we effectively required that commercial health plans fund patient-centered medical homes that meet certain OHIC definitions of patient-centered medical home status. We convened two working groups or two committees, one focused on care transformation and one focused on payment reform. Our method of doing policy here, particularly as a small state where we can get everyone in the same room, and you can really rely on peer pressure and transparency to kind of keep people focused on social interest outcomes. We use these committees to develop policy. So every year OHIC would convene these committees. We would develop a plan which would consist of a set of new requirements for health plans to follow in their affordability strategies. We would refine definitions. So when we developed APM targets, we had to first define what was an alternative payment model and develop a mechanism for accounting for payments and assigning them to APM status. For care transformation, we had to develop what competencies we thought were valuable or most valuable in the patient-centered medical home. So we focus on quality excellence, quality improvement. We focus on efforts undertaken by practices to manage medical spending in their panels. And so we ended up setting up a system where practices would report to OHIC every year, and they still do, on their quality measure performances as well as their NCQA status and their efforts to engage in cost management. And we recognize certain practices as patient-centered medical homes, which entitles them to the ongoing funding to support transformed primary care. That annual process of meeting with the committees and working out those plans is what I have here as the annual policy documents, which establish new rules and work streams. So that's a lot that we changed about the affordability standards in 2015, but I'm actually not done. We did a little bit more. To go along with this new focus on accountable care organizations as new entities in the market, we wanted to ensure that ACOs that had market power could not leverage that into higher than fair budget trends. So we actually established a cap on the annual budget growth that health plans could pay to accountable care organizations after you provide for some risk adjustment. And given this shift to value-based payments, we wanted to ensure some consistency and reduce administrative burden being confronted by providers from having quality measures in a suite of contracts across their payers. So we developed aligned measure sets for primary care hospitals, accountable care organizations, and behavioral health providers, which have core measures which have to be in value-based contracts, and then limit further selection of measures to a menu. And finally, particularly relevant to our focus on primary care, we put a lot of emphasis on transforming primary care and using the PCMH as the delivery system model. But we asked, have we really supported transformed primary care with a payment model? The supplemental payments to fund care management are great, the infrastructure is there, but are there things about the medical economics of primary care practices that are based on fee-for-service reimbursement that could be changed if we packaged fee-for-service into a prospective payment? So we held a series of work group meetings with the public, with the health plans, the providers, to develop recommendations around the construct of a primary care alternative payment model. All right, this slide here just gives you a link to some of those annual alternative payment methodology and care transformation plans if you're interested in reading up on those. And again, I've got a couple of slides that show the outcomes. We actually track commercial payer payments under APMs on a semi-annual basis, and we established targets for 2016 of having 30% of payments under an alternative payment model, increasing to 50% by 2018. This chart just shows you there was a marked increase in the use of alternative payment models in Rhode Island. 2014 was our baseline year. 2015 was the year that the regulations were promulgated and we defined APMs, and then subsequently we saw a pretty sharp uptick in their use. We've also observed a pretty sharp increase in the use of total cost of care payment models that have a downside risk component. So this chart just shows you the universe of allowed claims that are paid under a population-based total cost of care arrangement, and it distinguishes between the aggregate number of claims for attributed members in upside only versus in downside risk models. And so you see around 2016 there was a shift in the preponderance of dollars paid under total cost of care arrangements were paid in a downside risk or risk-sharing model. So now we're moving to the third wave of the affordability standards. You know, the market changes, healthcare is complex, and affordability is a really challenging and sometimes perceptibly intractable problem. And so you have to change your strategy, and I think that what you do as well in the past certainly conditions what you can do in the future. So those investments we made in primary care were absolutely foundational to our decision set as policymakers as we enter 2020. Some of the stuff that I'm about to show you that we've proposed would not be possible without the increases in primary care investment and without the work that Deb's group with the Care Transformation Collaborative have done around advancing primary care. I do want to say, just as a qualifier, that the proposed revisions are subject to change pending final rulemaking. We've received about 60 pages of comments on the proposed amendments, which we're working through now. So some of what I'm about to present will change a bit. The high-level goals of the version 3 or third wave of the affordability standards are to, again, ensure sustainable funding for advanced primary care. I think the next frontier for us is to support the integration of behavioral health into the primary care practice. And there are a few ways of doing that. One is by identifying potential administrative barriers to integration in terms of payment policies, plan design, and the other is just around payment, ensuring that the actual infrastructure and the human resources are paid. And thirdly, continuing to focus on the transition of payment models to greater downside risk and prospective payment with the intent of strengthening incentives for cost reduction and allowing the greater clinical flexibility and support for team-based care that's possible under prospective payment as opposed to fee-for-service-based payment. This is just to show you that we're in the midst of doing the rulemaking. This is a link to some of the rulemaking documents. We made revisions to our regulation, which contains the affordability standards, but in order to adequately help the public assess the changes, we also wrote a 50-page document. It's really detailing what the changes are, what the rationale for them is, and if you're interested, you can find those by clicking on this link and going to the Rhode Island Code of Regulations website and navigating to the Supporting Documents tab. So next wave, again, we're going to continue to focus on payment reform and care transformation as these mutually necessary and reinforcing sets of strategies with state oversight to help keep them together. But we are proposing to establish standards governing risk-based contracts. We actually have done this a bit in the past where we are proposing, you'll notice that from that previous slide, there was a chart showing the uptick in the use of risk-sharing contracts, but the risk assumption in those contracts, in our judgment, was fairly minimal. And so in order for a total cost of care arrangement with risk to really motivate behavioral changes, you need to have a meaningful level of risk assumption. So we're proposing to add some requirements around common parameters of risk-based contracting, which I can get into a bit later. We also want to address primary care payment. Again, we've invested a lot in primary care. We focused on primary care practice transformation. So we have infrastructure at the practice site. They're focusing on their quality measures. Most of them are participating with accountable care organizations, so there is some total cost of care awareness and discipline. But can we further reform primary care payment to unleash potential transformations at the clinical level, which are not possible or supportable under fee-for-service? So we have some ideas there. Also, we have ideas around alternative payment methodologies for specialists, which has been a really difficult issue to get at, in my opinion. And finally, we've got the hospital rate regulations in place, but there are existing, or there were pre-existing disparities in hospital payments across our acute care hospitals, and we're proposing some modest changes to allow for a value-based rate adjustment to certain eligible hospitals that are compensated below the median. I can go through some of these slides fairly quickly. This change to the regulation is just to say that we don't want to lose ground on the work we've done around payment reform, and we're going to set in place a minimum floor of having 50% of a commercial health insurer's medical payments made through an alternative payment model. Naturally, the alternative payment model of choice to achieve a target so high is going to be a total cost of care arrangement. I think that's by design. That's the way the targets are established. In terms of risk-based contracting, we're incorporating what we're calling minimum downside risk standards into the regulation, again, to motivate these behavioral changes, these changes in the incentive structure confronted by providers. We vary our standards based on types of ACOs, and we differentiate between two types of ACOs. That's ACOs including hospital systems, and then those that are just primary care group physician-based. The theory being that the ACOs including hospitals would have a greater capacity to bear downside risk based on total cost of care, as opposed to, say, downside risk based on a percentage of provider revenue, just because they have a higher level of net patient service revenue because they provide a greater breadth of services than a physician-based ACO. And accompanying the minimum downside risk requirements, which place some standards around those parameters of risk-based contracting, such as risk exposure caps, minimum loss rates, and risk-sharing rates, we're proposing to have commercial health insurers in the state by January 2021 have 30% of their Rhode Island resident insured covered lives attributed to a risk-sharing contract. The idea there is we ultimately want changes in payer contracting with providers to influence medical expense trends. And those are the medical expense trends which are used to establish health insurance premiums. And so I don't think you can have a effective model, a model that will affect changes in medical expense trends enough to influence premiums unless you have adequate coverage of that model. So having only 5% of your members in a downside risk model isn't going to influence medical expense trends sufficient, but having 30% or more is I think closer to adequate coverage. I referenced some of those common parameters of risk-based contracts and the different types of accountable care organizations. I'm not going to go through this slide in any depth. It's available. It will be available to you after the webinar, but this is just what we proposed based on our discussions with the local actors in the healthcare market and what we think are minimally necessary levels of risk assumption in contracts to motivate behavior. And this is just the same version of the previous slide for physician-based ACOs. You'll notice that the requirements would state that hospital-based ACOs should bear risk based on a percentage of total cost of care, whereas physician-based ACOs have a choice between percentage of total revenue and percentage of total cost of care. The theory being that if you require physician-based ACOs to bear total cost of care risk, you could potentially imperil their financial condition depending on the level of risk assumption, because their underlying patient service revenue is based on the provision of physician services like primary care visits. So we just want to be cognizant of that. Primary care payment reform I spoke to earlier. We think that's a necessary step towards advancing the transformation of primary care and further leveraging primary care as a mechanism to promote affordability. The proposed rules would require commercial health plans to develop and implement a prospectively paid alternative payment model for primary care. Furthermore, we are proposing to classify certain primary care practices as qualifying integrated behavioral health practices, which would not only benefit from other incentives in the regulation to do integrated behavioral health, but would also be extended a payment model under this provision that would compensate the practice for the primary care and behavioral health services delivered by the site. This requirement is drafted with, I think, some degree of flexibility by design, because there are different ways you can model prospective payments. You could do full capitation, you could do partial capitation. We want to ensure that there's some flexibility there, since this is so new. for payers and providers to mutually negotiate arrangements which make sense for them. So it's just a policy trade-off between being flexible versus being prescriptive, and that's what every regulator confronts on a daily basis, that trade-off there. We also propose to have a certain percentage of the health plan's Rhode Island resident members attributed to a primary care APM, beginning with 20% of them by January 1st, 2021, increasing to 60% by 2023. I can tell you from the public comments we received from the interested parties that they feel that this schedule of increase is quite aggressive, and we agree with them. So this is one area that it will likely be subject to change in terms of the out-year targets. Again, I'm not going to spend a ton of time because I want to make sure that there's ample time for questions, but for certain payers that have at least 30,000 covered lives, we would require that they implement alternative payment models with specialists, and we give them a menu of specialties here that we consider high impact, either because the total cost of services offered by them or the variability in cost of services. I'm not going to go through this in detail, but again, it's available to you, and this is also something, since all that I'm discussing now is potentially subject to change, it might make sense at some point in the future to regroup on this and figure out where we ultimately landed. Again, it seems that the primary interest of this audience is around primary care, but the level of funding available to primary care is kind of contingent on the funding that is accruing to other providers in the healthcare system. So perhaps you are interested in hospital payments. This is just to say that we agree with some hospitals that there is a rate disparity in the state, that some hospitals may be disadvantaged by differential payments, and that there should be an opportunity for them to increase their base rates if they meet certain quality requirements in exchange. And so this is the goal of the policy. Again, we received a lot of comments on this coming from different perspectives, and so this is something that we're continuing to look at. And then finally, around care transformation, we've had existing requirements from the 2015 or second wave of the Affordability Standards that commercial payers support patient-centered medical homes that are recognized by OHIC with funding to support care management on an ongoing basis. And so we're just extending that as well. I also mentioned earlier that we were proposing to create a distinction for certain practices that are integrated practices that is capable of delivering behavioral health within the primary care practice. They would receive certain benefits under this regulation related to the payment model that we were proposing around primary care, as well as we had some proposals around the imposition of co-payments for same day, same location physical health and behavioral health services. But I will show you a report on the next slide where you can, again, click a link and read that if you're interested in some of the ideas that we had there. And that gets to addressing some of these integrated behavioral health barriers. And here's the report. We convened a work group early in 2019 to focus on what we thought were, or what we learned from providers were some of the pain points when it comes to delivering integrated behavioral health at the primary care practice. And so this report will walk you through some of those that relate to plan design, payment policy, screenings that we are addressing in the regulation. So that's an overview of what we proposed. I've given you links to the resources externally if you want to do more reading about them. And in the next couple of months, I think OHIC will have more finality around what this final set of requirements is going to look like. But I think you should take away from this today that not only has OHIC placed a traditional emphasis on primary care as being extremely important and foundational to a well-functioning healthcare system capable of promoting affordability, but we continue to hold that sentiment and we continue to exercise our statutory powers in a manner that supports the investment in primary care, supports the emphasis on care transformation and payment reform, and carries that forward. So with that, I will conclude and I will invite your questions.
Corey, thank you very much. That was a terrific presentation, and I'm going to unmute all of our colleagues. Who I muted. My apologies. There was a fair amount of ambient noise, but everybody can now speak and ask some questions. Looks like there is one question that's come in on the chat, so I'll start with that from Dr. Shank in Ohio. First of all, thank you for a good presentation, and asked if you can speak more to the impact on the commercial payer market and their employer customers' reactions. And then there's a couple of other sub-questions, but I'll let you deal with that one.
Yeah, that's an excellent question. So something I didn't address is, what does this look like from the perspective of the employer, who is the ultimate purchaser of the health plans and who will ultimately bear the cost of promoting this transformation? This money, which health plans pay to primary care practices to support transformation, in which they pay to ACOs to support success under APMs, doesn't just come out of health plan reserves. It comes from premiums. It's priced into premiums. I think that we have all tried to do as good a job as we can to articulate to the employers that some of these models, while they may be untested, they do potentially improve the value of care that's being delivered to their members, and that it could potentially improve healthcare system performance and reduce cost trends, and ultimately improve affordability. Now, once you get into that, you're dealing with counterfactuals. If you're reducing cost trend, you're bending the cost curve, and the employer group gets quoted a 6% premium increase. They might not care so much that it could have been 8% absent the interventions that we're proposing here. There have always been an outstanding issue around plan design. So our market, our small group market in particular, likes very rich products. I think we have the highest average actuarial value amongst states, or at least one of the top 5 when it comes to small group products. And so that, of course, means there's lots of utilization, open networks, and a lot of these payment models will rely on, I think, narrower network conceptions, so that patients are parts of systems of care and their care is coordinated and then referred to higher value providers. So hopefully that gets to some of your question. It was a bit broad. Maybe some of the sub questions are more.
Sure, I'll just read the two of them now in a row. First of all, a question: did bending the cost curve include all the payers? And then was there any effect on cost shifting between public or government programs and commercial premiums?
Excellent questions. So the health affairs study and the chart that I showed earlier focused just on commercial members, but by commercial we mean fully insured, which is the segment of the market that OHIC regulates, and self-insured as well. Some of our regulations actually spill over and redound to the benefit of self-funded groups, because to the extent that they use third-party administrators that are also health plans subject to OHIC's jurisdiction, they can benefit from the hospital fee schedule inflation caps and whatnot. So what I showed you was specific to the commercial market, though in the state, we're well aligned with our Medicaid program to try to improve cost trends overall. In terms of cost shifting, I haven't seen evidence of that recently. We did a study in 2012 looking at hospital payment variation in the state, and I think it concluded there was no cost shift at the time. But I also think that in terms of our hospital fee schedule inflation caps, it forecloses the mechanism that powerful hospitals with market power could use to leverage increases to compensate for lower government payer reimbursements.
Thank you. So another question that came in was around patient-centered medical home recognition, and whether you have a OHIC specific recognition program, or if you're using like an NCQA or URAC type of recognition mechanism. And also, have you found that having that support for patient-centered medical home recognition to be a return on investment that's useful to you?
Excellent questions. So our definition is based on the NCQA recognition. That's the first requirement, so we have that external verification of transformation, but we go a step beyond that in that we require the practices to implement a set of cost management strategies. We used to prescribe what those strategies were, so it would be specific requirements around care management, use of data, open hours. I don't have the old requirements in front of me, so I can't be more specific than that. Now our cost management strategies are actually aligned with part of the NCQA recognition around healthcare resource stewardship. But our third component is quality performance. So we have a set of PCMH measures for adult and pediatric practices, along with certain benchmarks that they need to satisfy. And the practices based on their quality performance may or may not get the recognition. This year, all of the practices did actually get the recognition, which may mean that the quality thresholds are a bit lower than they should be. In terms of return on investment, we haven't done a ROI analysis specific to the activity of OHIC recognized PCMHs. Our large Blue Cross plan has done an analysis of its PCMHs, several years ago, and they published materials which it showed, at least according to them, that there was a return on investment, but they didn't publish like a paper about it or anything. I think conceptually the work of the PCMH early on may have been thought to reduce costs and generate return on investment, but now I think people are beginning to see it as part of a larger picture of providing foundation upon which you need to have commensurate payment incentives in order to generate the outcomes we want to see.
Great, thank you.
Yeah.
There's one point of clarification just to tell us whether the requirements that you've been describing apply to the Rhode Island's Medicaid program.
They do not apply to Medicaid because we don't oversee Medicaid. However, we are very closely aligned with the Medicaid program. They don't have a primary care spend requirement or anything, but they do have a healthcare system transformation project in which they're requiring their Medicaid managed care plans to contract with what they call accountable entities, which are just accountable care organizations using a total cost of care methodology. So we have very sound policy alignment, but the affordability standards don't apply to Medicaid health plans per se.
Thank you. Any other questions from, these have been coming in on chat, but everybody should be able to speak if you have questions that you'd like to ask.
It's Pano here, Council CTC. I just might make a comment around the Medicaid alignment, and for folks familiar with, obviously, and most of us are, with primary care first and CPC plus, even the push from OHIC side to support primary care capitation is certainly along that line. Medicaid has really, at this point in Rhode Island, has been slow to get onto that push because they put all their focus on the accountable entity, ACO kind of piece, with a lot of focus on social determinants and other kinds of activities. So it's some of the limitations that OHIC has, even though they've been a tremendous partner and driver of a lot of support for change. And there is alignment, but it's not been fully aligned. And that's maybe some of the opportunities going forward, is to get Medicaid to kind of come on board with primary care payment reform.
Right, and we continue to have those conversations. And in fact, I had a conversation with them yesterday about some of this work.
This is Richard Trunk in Ohio again, and I guess I'll just chime in. You mentioned that that Rhode Island is one of in the top 5 actuarials for the states. Can you talk a little bit about that? And is that a lot of ability to maybe make impact because you guys are a fairly high cost, or am I reading that right?
So since I have my computer in slideshow projection mode. I can't pull up the study we did, but we looked at federal data that they collect as part of the risk adjustment program, and we wanted to get a sense of how generous our small group plans were on average compared to other states. So I think it's top 5. I can follow up with the specific number, but in general, the takeaway was our small employers tend to select richer plan designs. That's well known. It's out in the open. A lot of that has to do with the fact that small employers pick a plan that they want for themselves, and that's what they give their employees. So I think that's largely the calculus there. In terms of our small employer rates, so once you adjust for the richness of the benefits and I think the morbidity in the population, we actually have not a super high average premium, and again, I can send through Lisa after the analysis that we did if you're interested in looking at that. It's a bit dated now, but I can share that with you.
That'd be good. Yeah, I just my experience in Ohio with the employer groups, and we're a CPC plus state, and is to convince them that that this investment in primary care is worth it, and that there is a return on investment for them. My concern is that for this to be really sustainable in primary care, I need to have all the payers involved, and we do have. We got 5 major payers and about 4 or 5 other smaller commercial payers. And so I'd be interested. Rhode Island, do you have 1 or 2 or 3, or how? What kind of major payer participation do you have in this state?
We have 4 major commercial payers. Our market is fairly dominated by Blue Cross Blue Shield and United Healthcare, and one of our commercial payers is also the dominant Medicaid managed care plan. So it's not as many payers. To your point about engaging employers and trying to convince them that these investments are worth making, we have a health insurance advisory council where we have some employer representation, and we also convene ad hoc meetings. Like right now, we have a working group focusing on the health of the small group risk pool, and some of the discussions around that table have been around what is going on outside of rate setting to improve cost performance.
Yeah. That's good.
Any other questions for Corey?
And I can just offer, so there's a lot of momentum, it appears, in the country around this concept of affordability standards. We've gotten a lot of requests from other states about the work that we're doing, and we have calls with them, and each state is pursuing a somewhat different strategy, but people are focusing, or policymakers are really focusing on affordability. So if there are any state folks on the phone who are interested in learning more about the work that Rhode Island is doing, or if you're thinking of doing something yourself and you want to get our guidance, feel free to call me up. I'm always happy to talk about this stuff with my peers in other states.
Thank you, Corey. And I think that people are going to be taking you up on that. So we'll be sharing the various documents that were mentioned both by Corey and Deb, as well as these slides we'll have available on our website. And this has been a recorded webinar, so there will be an available recording that you can get through our website as well. Once again, Corey, thank you so much for a really wonderful presentation of very complicated material with long history. And it's a great connection also with our Millbank Memorial Fund president, Chris Kohler, and the legacy he has left you in Rhode Island. So thank you very much for connecting those dots. We have a webinar next month. We have colleagues from New York State who are going to be describing a very exciting and successful process they did to align their quality measures statewide, which is something that has been at the top of a lot of people's lists as they're trying to work in this multi-payer space. So stay tuned for more information about that. And once again, Corey, thank you so much. Deb, thank you for your helping to arrange this. And everybody have a good rest of your day. Thank you.
Yeah, thank you.
Thanks.
Okay.
It was a pleasure.
Thanks.
Thank you.